dystrophin and dystrophin-associated muscular dystrophies. She then did her residency training at Seattle Children's and the University of Washington here, then went down to Stanford University for her neuromuscular fellowship training with Dr. John Day and Dr. Carolina Tessie Rocha. And now she is junior faculty at the University of Michigan. We're so happy to invite her back to Seattle. And with that, please take it away, Dr. Lin.
Thank you so much, Dr. Ko. Today I was hoping to discuss a little bit more information with regards to two common pediatric neuromuscular conditions that we see and the ever-changing landscape with the advent of disease-modifying therapies. And so, of course, I don't have really any disclosures. The two conditions that we will focus on today is spinal muscular atrophy and Duchenne muscular dystrophy. Essentially, as a quick reminder for people who have perhaps have not had a chance to come in contact with spinal muscular atrophy for some time, this is a condition that can be most severe in the neonatal age, the type 1, where the patient, there we go, oftentimes presents in the neonatal ICU with really bad paradoxical breathing, requiring respiratory support, and then needing tube feeding support at the same time as well. These patients oftentimes do not show any signs of encephalopathy that would be concerning for like sepsis or other causes for this diffuse hypotonia, breathing, and feeding difficulties. They would have the traditional tongue fasciculations and absence of reflexes. On the other hand, for Duchenne muscular dystrophy, it's an X-linked disorder, and so we see them in boys, and they typically present in those later toddler years with this characteristic waddling gait and pseudo hypertrophy of the calves. They would also have the classic Gower sign, having difficulty getting up from the ground due to significant proximal weakness. As the disease progresses, these boys oftentimes will lose the ability for ambulation around age 12 or so, and around the second or third decade, then they start to look at pretty significant cardiopulmonary decline and potentially needing to face some end-of-life decisions. And so the field has been exceptionally exciting for over the past decade or so, given the advent of several disease-modifying treatments that have not previously been available. And that's for both the spinal muscular atrophy and as well as for the Duchenne muscular dystrophy. I'm so sorry about this. Essentially, as I try to speak over it, the sound stimulation. The SMA type 1 babies, the natural history is that these patients will have significant difficulty with respiratory and feeding, and unfortunately have a hard time surviving past age 2. These patients will never be able to sit up on their own, and yet you see this SMA 1 baby here being able to walk around and enjoy life after getting the gene therapy construct Zolgensma that was approved by the FDA in 2019. So it's quite significant and definitely changing the landscape of their care. On the other hand, for Duchenne muscular dystrophy, excuse me, let me see. There we go. We would see, remember the previous video where you see the boy trying to waddle through the hallway and having some distinct challenges. And here we have a similar boy of a similar age, and yet look how well he's actually able to run. Definitely the run and the gait is not entirely normal, but in comparison, he is able to do a lot more compared to the boy we saw previously. There we go. So over the years, in terms of thinking about disease-modifying therapies, there have been several domains explored. Today, for the majority of our talk, we'll focus on using the adeno-associated viral delivery of gene constructs. But other fields that have really taken off and have agents that are FDA approved for the treatment of these muscular conditions include use of exon skipping methods. There is and also the stop codon read through. There are up and coming research in looking at an actual gene editing mechanism through the CRISPR-Cas9 system, but there's a lot more technical difficulties that we will need to overcome before it is ready for prime time for trial in humans. Now, looking at the idea of AAV gene therapy, the thought is that if you have a genetic mutation rendering a key protein responsible for the health of motor neurons or skeletal muscles, what if we deliver the correct blueprint, the correct DNA into the target cells? And so in order for us to achieve that, there has been several delivery systems investigated, a lot of them along the lines of viral vectors, given their easy bioavailability. So definitely in selecting a system, we want good efficacy, good bioavailability to the target organ system. We want to be able to house a transgene size that is more variable, hopefully without any limitations to the size of the gene that it can carry. We don't want the viral vector in the delivery system to trigger unwanted immunogenicity. And we definitely do not want off-target effect from incidental nuclear integration into healthy DNAs. And ideally, we would be able to get this construct into both the dividing and non-dividing cells, which is particularly important when it comes to treatment for skeletal muscle, as over time, we definitely do have a turnover of that cell. Now, during the early days, there has been several viral vectors tested, and these were some of the forerunners back in the day in the more of the early 2000s, I want to say, and out of which one of the vectors showed the most promise is the recombinant adeno-associated virus because it doesn't have any risk of having insertional mutagenesis. It delivers the gene the transgene as an episome that it would be outside your nuclear DNA. Another reason for why the recombinant AAV vectors have been a popular choice is because there are several serotypes. There's always a concern that we have a natural immunity already to some of these viral vectors, and then incidentally, the patient will destroy whatever we try to deliver. But the initial thought is that with these various serotypes available, in the event that we do develop immunity towards one serotype, then we can try to use a different serotype delivering the same transgene construct. However, as time goes by, we realize that unfortunately life is not that simple. A lot of it does depend on the tropism of these serotypes towards target tissues. The two forerunners in terms of using these serotypes for transgene delivery include the AAV2 that predominantly goes into CNS, a little bit in muscle, but more from a CNS perspective, and AAV9 that is more muscle specific. AAV6 is also relatively good in terms of muscle penetration. However, it tends to be used when we are more targeting the heart as opposed to the skeletal muscle. AAV9 is still superior in the penetration into skeletal muscle. Now, for the requirements, right, definitely for efficacy and bioavailability, at the time of, 2010-ish, this is one of the best foot forward. Size of the transcript is an issue, though, because it is an adeno-associated virus, so it's not quite able to deliver a large transgene. The limit is about 4.4 kilobases, and the larger the transgene, the further reduction in the efficacy and bioavailability of what is delivered. Immunogenicity tends to be lower than most, and absolutely no off-target effect from the nuclear integration like we talked about. Though unfortunately, it doesn't quite get into dividing cells, such as satellite cells or muscle stem cells. But then perhaps this is not as big of an issue when it comes to spinal muscular atrophy when we're trying to deliver these constructs into motor neurons that doesn't have a, turnover. So, first up, to talk a little bit more about the treatments available for spinal muscular atrophy, this disease model ended up being the perfect platform to test out using the recombinant AAV gene therapy. Now, the pathophysiology of SMA is that for any healthy individual, we have both the SMN1 gene, or SMA1 gene, and the SMN2 gene. The difference between the two is that in SMN2, there is a single nucleotide change causing an inadvertent skipping and exclusion of exon 7, making it internally truncated SMN protein. For people with SMA, what happens is that the SMN1 blueprint, the DNA, is either non-existent or non-functional, and we essentially rely on our ability of the SMN2 to accidentally skip over the splice site and create full-length protein. And with that very little full-length protein that it would accidentally read through and generate around 10% or so, then we are able to at least keep up a little bit of the health in our motor neurons. Now, we have more than one copy, typically, of the SMN2 gene. Everyone is a little bit variable. And so the more SMN2 copies that you can imagine in SMA patients, the less severe the SMA symptoms can be. Now, it's not that straightforward as all biology goes, of course, because we have come to learn that the SMN protein is not only very crucial in the health and maintenance of anterior horn cells, but it definitely causes a lot more systemic impacts as well. But that said, it would be a first step using this as a way to try to deliver a correct copy of the transgene into the anterior horn cell. And of course, this gene is much less than 4.4 kb and very suitable for the recombinant AAV9. And so the first trials, of course, looked at the most severe form, the SMA type 1, where these kiddos never gain the ability to sit independently, heavily relying on respiratory and tube feeding support, and oftentimes death by age 2. In 2014, there was the initial trial led by Dr. Led by the team at Nationwide Children's, Dr. Mendel, in looking at 15 of the SMA type 1 babies, all under 8 months of age, 3 in the low dose group and 12 in the high dose group. And the result was really significant. So here we have the low dose results and those in the high dose results. On the y-axis, we have something called the CHOP Intend score, and this is a compounded motor score, function score, that is targeted towards developmental ages of anyone less than age 2, with full score being 64. And so one of the things that they first noticed that even with low dose AAV, they're not showing a decline in the CHOP Intent score as one would anticipate for such a progressive disorder. And in fact, in the high dose AAV, several patients, particularly if dosed fairly early, are able to gain almost full strength and is comparable to other healthy children of their same age. So this led to the very exciting publication back in 2017 of the efficacy of using recombinant AAV gene therapy for treatment of spinal muscular atrophy, and subsequently the approval for this gene therapy to treat pediatric patients in 2019. Of course, it comes at a cost, a whopping $2.1 million. Now, one of the questions we always have is, well, okay, great. This drug is now approved. It is showing some initial benefits, but what are the long-term implications for these patients after receiving this treatment? Since Zolgensma, the AAV gene therapy construct, was just approved in 2019, we only have about, 6-ish years of data after it is marketed. So it's still a little early days to tell. But Zolgensma is not the first disease-modifying therapy or gene therapy approved for SMA. There was, prior to Zolgensma, the idea of using antisense oligonucleotides to help block the nucleotide change in SMN2 to allow better inclusion of exon 7 has been proposed and FDA approved. So the results from this particular construct is in the ENDEAR trial, leading to the FDA approval of nusinersen, or otherwise known as Spinraza, for the treatment of SMA in 2016. So over time, we do have a little bit more data on the efficacy of Spinraza. And so what we find in a lot of the literature looking at long-term outcomes is that it tends to be a combination of the outcomes from both exon skipping and gene therapy delivery in a single paper. So some of the lessons we've learned, particularly from the exon skipping data, is that while the number of SMN2 copies correlates with disease severity, but this is not exact. Looking at several population studies, looking at the percentage of ambulatory patients at the start of treatment, and the number of copy numbers of the SMN2, we find that particularly with 3-copy variants, it tends to be, their severity tends to be much more variable. So in the past, when we think about the traditional non-sitters and SMA type 1, we think about people with, 2 copies or less of the SMN2, but we find that that is not exact. When the Spinraza first got approved, there were several institutions, or several, I should say, insurance companies who are unwilling to approve treatment for the SMA patient, even though they show a severe phenotype akin to SMA type 1, because they have 3 copy numbers. But we find that it's not a very exact science. The other thing is that in SMA, earlier treatment leads to better outcomes. And this sort of corresponds with a lot of the basic science observations that without good SMN protein, the motor neuron destruction starts actually in utero in that 3rd trimester. So in the situation of SMA, really time is motor neurons. And so here we are seeing a graph looking at the fraction of patient sitting according to age, standing, and walking. And the various color lines reflects the time at which they received, started to receive either nusinersen or Zolgensma. And you can see that, of course, the earlier the treatment, the better in terms of outcome gains. And it's even better to treat pre-symptomatically, and it sort of makes sense, particularly knowing that the motor neuron destruction does start as early as the 3rd trimester in utero. Now, as best as we can, right, as promising and as amazing those SMA videos look, we aren't really there yet in terms of curing SMA. We are, though, effectively pushing the SMA phenotype so that the people who were going to be non-sitters are now starting to do a lot more. Now, we are able to make those good motor gains, but it's important to look at the patient as a whole and think about what are the other common complications that is associated with SMA, particularly the type 1 patients, and what these disease-modifying treatments mean for them in the long term. First of all, thinking about the respiratory function. So at first, it held a lot of promise because we thought, well, if we're able to improve the skeletal muscle strength, then we should be able to improve the bulbar and respiratory strength to a certain degree. But we were a little surprised to see that actually, from a day-to-day perspective, a maintenance pulmonary regimen, these children still require about the same amount of respiratory support as prior to the availability of these disease-modifying treatments. With a caveat, though, these patients do much better during upper respiratory infections. They are able to recover from it a lot faster and are able to tolerate our traditional interventions and support a lot easier. As a result, in the sort of the inpatient setting, if an SMA type 1 after gene therapy treatment comes in with acute upper respiratory infection causing acute respiratory decline, it is no longer a big fear to intubate that patient to help with temporary respiratory support because these are patients that are now going to be extubatable, and extubation is no longer as big of a concern as it was previously. What about the orthopedic aspect of things? So before the advent of disease-modifying therapies, for SMA type 1, these patients can develop scoliosis within the first year with a whopping progression speed about 2.3 degrees per month. With SMN2, the mean progression is about 5.2 per year. And of course, typically with scoliosis, we like to start doing intervention around 20 to 30 degrees. Otherwise, the worsening tends to be a little bit more accelerated and exponential. But regardless of whether or not we consider surgical implementations versus soft bracing, definitely it has a significant impact on the lung and thoracic development, particularly in these young infants and toddlers. So here are some examples of SMA patients. You see how severe an SMA type 1 that scoliosis can be. And even after surgical correction, they oftentimes still would require bracing, particularly as they grow and lengthen. What was a little bit disappointing is to learn that despite the improvement in the CHOP INTEND score, the incidence of scoliosis is actually not impacted. And so it's not necessarily that I have better CHOP INTEND scores, better motor function, that I am better protected from scoliosis. Clinically, what we're noticing is that these patients, while able to gain better motor milestones, it's still not perfect. And so these traditionally non-sitters are now able to be at the brink of to sit, but now the floppy muscles unfortunately have to start accommodating a growing spine, and so the early onset scoliosis still is a big concern in the SMA type 1 field, despite these disease-modifying treatments. And again, it comes to a difficult challenge because even with soft bracing at this early age, we are at a risk of causing further thoracic deformities and lung impairments, restrictive lung disease, etc. Now, what about growth and nutrition? So we know that for untreated SMA type 1 patients, they experience bulbar degradation between 5 to 12 months of age. And then after disease-modifying treatment, if you use exon-skipping nusinersen, about 84% of the patients are able to maintain full oral nutrition. 100% of those treated with Zolgensma were able to maintain full oral nutrition. However, there's a caveat behind these numbers, is that for Zolgensma, they really targeted young patients, right? Patients ideally under 6 months and under, whereas for nusinersen, it was the trials expanded the age range quite a bit. And so it's not exactly comparing apples to apples, it's a little bit apples to oranges, but regardless, it does suggest some sort of stabilization in terms of their bulbar function. Risdiplam is another newer agent that allows the same exon skipping capabilities. That is an oral tablet diverged systemically. And there is a little less clarification on the data that was published, but it does seem that it remains beneficial in maintaining the patient's swallow capabilities. The other aspect with regards to bulbar function, feeding by mouth orally, is the fact that despite the strengths of the disease-modifying treatments, their baseline respiratory maintenance needs haven't really changed all that much. And a lot of these patients do require chronic non-invasive positive pressure ventilation. And with chronic use, unfortunately, at such a young age, it's quite easy to develop mid-phase malformations and making basically your entire structure in that chewing and swallowing oral cavity aspect to be a lot different. And so there is an additional piece to this bulbar function as well. Now, in older patients with milder forms of SMA, we know that they unfortunately aren't without additional nutritional issues, which includes that they tend to have a higher percentage of fat mass despite having a normal BMI. Definitely, if you're able to maintain ambulation, the closer to normal that ratio would be. And that despite it all, more than 90% of these patients would have some sort of metabolic abnormalities. And so the jury is still out, but we may need to pay closer attention on these kiddos as they grow up to see if they are more at risk of developing metabolic syndromes. So next, I would like to then talk about the second disorder, as promised, Duchenne muscular dystrophy, which is near and dear to my heart. So actually, the road for gene treatment or disease-modifying treatments for Duchenne started long before Zolgensma, but Zolgensma for spinal muscular atrophy ended up being such a perfect fit in terms of that disease model that definitely once that the research and trials started, it advanced at a much faster rate than what we were able to do for Duchenne. So this was the first clinical trial paper that is more pertaining to the current microdystrophin gene therapy constructs, where Dr. Mendel and Nationwide Children's treated 6 boys with, again, a low dose and a high dose, recombinant AAV, delivering a dystrophin transgene to intramuscularly, actually, to see if there are good expression of dystrophin, to evaluate for any issues with immunogenicity, etc. Now, one of the things in retrospect that people realize was this was also one of the first trials that used a commercial company to make the AAV vector delivery system. And unlike the prior trials, which these constructs are manufactured strictly in a science lab, in a lab setting with very tight quality controls, when you try to mass produce such a delicate construct, there are other factors that become a factor into it as well. The other thing is that unlike the SMA, where we have SMN1, SMN2, and our body is used to seeing different parts of that SMN protein, in Duchenne, that's a little bit different. We find that actually, because of the lack and paucity of the protein dystrophin in these patients' skeletal muscles, there is a certain amount of innate T cell autoimmunity against dystrophin in itself. So back when I was a trainee, definitely the Holy Grail was trying to perfect the system for treatment of DMD, and I had the distinct pleasure with working with several forerunners in this field, including Dr. Chamberlain here at University of Washington while I was a resident here. Now, the pathophysiology of Duchenne muscular dystrophy is essentially a malfunctioning or loss of dystrophin here in the costomeres. Dystrophin functions as an important mechanical stabilizer among other things, such as docking of nNOS for antioxidation responses. But the idea is that It binds on the N-terminus to the gamma actin, which is a part of the Z disc, and connects to our contractile unit. On the C-terminus, then it binds to the dystroglycoprotein complex, transmembrane protein that reaches out into the extracellular matrix. Therefore, as we contract, dystrophin will diffuse that lateral force out to the extracellular matrix, therefore preventing unwanted eccentric contraction injuries. Now, what happens if we don't have a good functioning dystrophin is that number one, we're not going to be able to organize the dystroglycoprotein complex in an effective way. And so we lose that benefit of connecting to the extracellular matrix. And with our repeated contractions, we start to then injure our sarcolemmal membrane, causing an influx of unwanted calcium, activating several calcium-dependent proteases and chemokines and cytokines, leading to muscle degradation, inflammation, necrosis, etc. At some point, our innate ability for regeneration is then limited, and we start to develop this progressive weakness as we see in our Duchenne boys. And so it undergoes the muscle weakening, the cardiac problems, respiratory dysfunction, and unfortunately facing end-of-life situations around the second or third decade of life. Now, another concept with regards to the pathophysiology of Duchenne muscular dystrophy is the in-frame, out-of-frame rule. So say that I have a dystrophin gene here. What we realize is that the end of an exon is not necessarily the end of a codon. So, for example, here between exon 50 and 51, the codon actually ends here. The exon ends in the middle of a codon. And so if you have a disease-generating mutation that takes out 49 and 50, then what happens is that you have a frame shift change causing subsequent downstream dysfunction, generating a malfunctioning dystrophin. And so with these out-of-frame situations, right, we really lose the function of dystrophin. It's not able to correctly localize to the correct position in the costomere, and you have a lot of dystrophic features on muscle biopsy. And so these out-of-frame mutations tend to lead to a more severe Duchenne. On the other hand, though, if we have a mutation that takes out, say, 49, 50, and 51, so thankfully not impacting the reading frame, we tend to then create an internally truncated dystrophin, but it functions much better. And so we typically see a milder Becker phenotype in that instance. For the milder Becker, we have patients that might be ambulatory even up to the age of in their mid-60s. Which is quite different from the traditional Duchenne's. Interestingly enough, these Becker patients tend to experience much more cardiomyopathy symptoms compared to the Duchenne patients, but that could also be because they are able to live a more longer lifespan from a natural history perspective. And so jumping ahead, there might be several providers recalling this very controversial approval by the FDA of exon skipping for Duchenne muscular dystrophy back in 2016. Indeed, at the time, the Duchenne community has been hard-pressed to look for viable treatments for these rapidly declining boys for some time. And there are several foundations and family support groups that are very vocal advocates of trying to push the drug discovery and availability to that population. There were some important findings that came out in the initial trial that led to the approval. But of course, at the time, there were several members in the FDA committee who were worried that those findings are not going to prove to be significant. So first of all, while these patients appear to have better motor scores in that 2-year follow-up, the amount of dystrophin staining in the muscle biopsies was concerningly low. So in basically we're looking at, yes, there was an increase, but we're talking about still staying at about 1 to 2% at most of dystrophin in these skeletal muscles, raising significant concern. That said, though, despite the initial concern, and the field did, continue to advance to try to perfect their technology. And the thought behind exon skipping, of course, is to help restore the reading frame. And so there are mutations that are suitable for skipping of different exons. And there has been several agents that are approved. Now, it also is not a very cheap treatment by far, but although per dose, I suppose it does appear much less than the one-time dose of the Zolgensma, the $2.1 million. But it was an ongoing concern, right, for between providers. We try to skip and hop these patients into the Becker phenotype, but at what kind of a cost? And the challenge, I think, is that long-term data does show some benefit, right? In terms of evaluating the cost-benefit ratio, that is challenging, I agree, but these treatments are not are definitely providing some support to these patients that are much better than the traditional using glucocorticoids, which only allows extension of their ambulatory years by about 2 years at max. So in looking at 2 different trials of exon 51 skipping, and looking at the mean 6-meter walk distance over a period of time, definitely in comparison with the natural history study here shown in the gray, they are able to ambulate a lot better, right, that compared to their non-treated cohort, despite being on steroids. Definitely there we see a promising change in terms of their respiratory function and breathing compared to the natural history studies of untreated patients. Those in these 2 different trials of exon 51 skipping showed promise in terms of slowing the decline of their FVC. And of course, they do continue to create dystrophin over time. And don't develop any concerns for immunogenicity or other things that would suddenly render this type of treatment ineffective. But then what about our holy grail of trying to use the recombinant AAV system? So why is this the holy grail since we already have the exon skipping method? Well, the answer is dystrophin is an enormous gene. It is actually the largest gene in the human body at a whopping size of 2.1 megabase. The cDNA alone is 14 kilobases. And so when we're talking about exon skipping, for example, the most popular exon skipping of 51, it only applies to maybe about a third or so of Duchenne patients. Whereas if we're able to deliver a transgene that functions better, then it's almost a one-size-fits-all kind of a situation. But the size of dystrophin definitely is a big limitation to using the recombinant AAV system because remember how it only really ideally holds about 4.4 kilobases. So if we look at the several Becker mutations and thinking that, well, how about if we make the first step of trying to turn Duchenne to Becker, similar to the exon skipping methods, maybe we can spare some parts of dystrophin and we might still be okay. And this comes from a family in the UK, this study published by Kay Davies back in, I think, the 90s, of missing almost 50% of that central area of dystrophin, and yet these patients remain ambulatory beyond age of 61. So then it comes an era where we start to look at various domains of dystrophin and to try to figure out what can be spared without much perturbation to the overall protein function. And then our Chamberlain lab here at University of Washington really pioneered this type of study looking at several internally truncated dystrophin gene constructs and testing them in animal models to look at efficacy. One of these constructs actually is the backbone of three out of the five companies that are actively pursuing using recombinant AAV transgene delivery for treatment of Duchenne, including the Sarepta, which is the only company currently that has an FDA-approved agent available for Duchenne kids. But then as we learn more and more about dystrophin, we realize that there's a reason for why, despite years of evolution, it is still preserved at this ginormous size, because every region does have its reason for existence. So for example, for people who are missing significant portions of the N-terminus, we find that they tend to have much more neurocognitive cognitive dysfunctions. So this brings me back to the fact that we traditionally think about Duchenne muscular dystrophy as a primary skeletal muscle, cardiac muscle disease, but that's actually not all it is. It is not uncommon for us to observe autistic spectrum disorders in these patients and epilepsy, actually, and particularly for those Duchenne boys with more of an N-terminus mutation leading to their disorder. The other thing is that if we look at the natural history of the various mutations that would be suitable for exon 44 skipping compared to exon 45 skipping, we find that their the severity of that disease definitely is variable. So here in the black line, we see the decline of all mutations across the board in the natural history study. And then those in the red and the yellow are the ones that are eligible for exon 44 skipping to turn into an in-frame mutation, those that are eligible for exon 45 skipping. And you can see that with or without glucocorticoids, right? The mutations that would benefit from exon 45 skipping definitely progress at a much faster rate than the mutations that would benefit from exon 44 skipping. So unfortunately, despite a big construct and the fact that maybe some people could sort of slide by with not having a portion of it, every piece of that dystrophin does play a critical role somehow. So it took a couple years, but we finally got here over the past 2 years with Sarepta as microconstruct being the forerunner in terms of better efficacy, and more significantly, they were able to demonstrate much less significant side effects associated with the treatment during clinical trials, leading to the subsequent FDA approval back in 2023. And so this is the data that led to the FDA approval where the Western blot had showed 55% of dystrophin staining, which is a lot higher than that of the initial exon skipping trials, and that definitely in motor skills, looking at the North Star ambulatory assessment, they see a 7-point increase in some of these patients 4 years post-dosing, whereas in the natural history, the average is that they lost about 8 points a year after age 7. So after the approval, they, of course, continue to provide more data and evidence with the confirmatory trial of EMBARK. This segment of the trial looked at patients aged 4 and above to less than 8 years of age and all ambulatory at time of treatment. Their primary endpoint, because of the NSAA benefit that they saw initially, was the NSAA, but curiously enough, they did not meet that primary endpoint. However, if we looked at other motor function tests, such as time to rise from the floor, 10-meter walk and run, they did seem to meet clinical statistical significance in terms of benefit. They also looked at other motor functions, including the SV95, which is the stride velocity in the 95th percentile. It is a way to measure peak performance of ambulation, the 100-meter walk and run, and time to ascend 4 steps. They all seem to favor treatment. Another thing that they did was to look at whole body MRIs, to look at the fraction of fat versus fraction of muscle. And an easy way to interpret this graph is if these bars are lower, you have more muscle. If these bars are taller, you have more fat. And it's not uniform across the board, but with treatment, versus placebo, some of these muscles definitely show better muscle content and less fat content. They divided into the 4 to 5 year old group and 6 to 7 year old group because when the FDA first considered approval of this gene therapy construct, they noticed that the NSAA seemed to be more convincingly better in the 4 to 5 age group compared to the 6 to 7 age group. And so back in 2023, it would be the approval was just for those in the 4 to 5 age group who are ambulatory. And so, after that approval in 2023, there was a lot of hype, a lot of excitement. The families were really hopeful about the long-term outcome of this treatment. And with ongoing promising safety data that Sarepta was able to provide within a year, basically, they opened the approval to all ages of Duchenne muscular dystrophy, ambulatory and non-ambulatory. Of course, in the prescription detail, Sarepta does say that we don't have as much information about non-ambulatory patients, so please use at your own discretion. But that said, the FDA did, open up the doors for this to be more widely available. And definitely, the caregivers are noticing on a day-to-day basis notable improvements in the function of their boys. But is it all that it's made out to be? So thinking about some of the risks. Now, we have known for a long time that recombinant AAV gets a lot of liver uptake and cause a lot of liver burden, regardless of what type of transgene we insert into it and what kind of disorder we're trying to treat. So this is a publication that looked at the Zolgensma for SMA, right, with how beneficial it is and the amount of burden it has on the liver. Now, majority of these patients, I would say really majority of the patients, will experience transaminitis that typically is asymptomatic and does calm down with advent of glucocorticoids or other immunosuppressants. And they tend to resolve over time without subsequent sequelae. But definitely, it's not the case for every type of muscular disorders. The trial of using the recombinant AAV was not very helpful, unfortunately, for the X-linked myotubular myopathy. It is after the unfortunate failed trials and death that we realized that because of how progressive this disorder is, we underestimated the impact of the disease underlying burden to the liver itself. And so these kids actually have liver that is impacted already by the myotubular myopathy and unfortunately overburdened them with viral vectors. And it really it was not a good combination. We even tried to titrate, right, the dose of the viral vector to see if we can sort of slide by and find a good middle ground. But unfortunately, that's just simply not the case. The liver is quite sensitive to the viral load. And then looking at the construct for DMD and looking at the side effects of the Sarepta compound that was FDA approved, they still have the typical nausea and vomiting that one often sees with this type of a treatment, and the acute and also the acute liver injury or the transaminitis that we notice. These were some of the more important things that people were worried about because, in comparison with dosing in SMA, with dosing in Duchenne, we are talking about a much larger viral load because the kid is bigger, and these doses are based on a weight-based dosing. There's a cutoff, of course, but definitely the dose range that are tried in terms of the exact vector grams that are used is much higher. Additionally, we find in more unique to Duchenne and not really seen in SMA is the risk for myocarditis and also immune-mediated myositis. The Immune-mediated myositis and carditis is really no joke. In fact, the Pfizer construct during the early stages of their clinical trial had an unfortunate death due to fulminant heart failure due to immune-mediated myositis that occurred as soon as a week after the dose. And then after this, there was a flurry of people trying to look into, is this from the vector? Is this from the dystrophin itself, et cetera, to try to figure out where the inflammation was triggered from? And we'll talk about that in a little bit. But then, even with the most promising treatment of Sarepta, which got FDA approval, there was an unfortunate death also earlier this year, sometime late February, where it was dosed in a 16-year-old, again, non-ambulatory male, who had initially the typical transaminitis that responded to the traditional immunosuppression treatment, but then all of a sudden developed acute liver synthetic dysfunction and DIC, followed by death. There might be some additional viral exposure for the patient around that time. It's a little hard to know. And the full autopsy report is, of course, still pending. And so definitely, the company tries to be as cautious as possible, but I think it's very important for us as clinicians to really be the gatekeepers, to really understand the risks of these treatments and the benefits. Really try our very best with the data at hand to review that ratio with the family, so that they can have better informed decisions moving forward. I don't know that this necessarily means we should scrap all these gene therapies, but families should be appropriately warned about the inherent risks associated with these treatments. And so, where is this inflammation coming from, right? Where should we be worried about? And if we think about immunogenicity stemming from this type of recombinant AAV transgene treatment, we look at a couple of areas, right? Basically, where you might have some innate T cell immunity, some pre-existing immunity, because your body isn't used to seeing dystrophin, and then some innate, again, innate immunities. And then after dosing, right, you might develop some adaptive immunity due to the exposure of the construct and the vector. Now, remember how we talked about back in 2010, the trial of intramuscular injections unfortunately caused significant inflammatory response, destroying the construct that was delivered. And that also brought up a very key point with regards to quality control during manufacturing of large-scale manufacturing. And basically, you really need a much tighter control and regulation compared to the making of other constructs such as the ASOs for exon skipping. In fact, there has been data that shows with each freeze thaw, right, we get more and more aggregation. And so the more aggregation you have, those aggregates are more immunogenic. They don't mount to anything beneficial from a clinical perspective. So how are we going to freeze this construct, make it stable, deliver it appropriately without it being damaged to anywhere here in the United States or internationally, and then have a chance to thaw it out safely and administer it to the patient? So it took a lot of more of an operations detail to perfect that. The other thing about dystrophin and Duchenne is the uniqueness of it compared to SMA, right? Like I mentioned, regardless, our body is used to seeing that SMN protein to a certain degree. And so we don't typically develop an autoimmunity against the transgene construct that we are trying to deliver. The case is not the same for dystrophin. What we find is that every patient can have what we call revertant fibers. And what they are that sometimes, even though I'm making this dystrophin that is really not functioning correctly, hard to localize to that costamere, hard to remain bound to the N and C terminus, hard to function, but somehow I'm able to still get some of this to that area and it sort of functions, right? It definitely is dependent on the type of mutation that you have. But then that would mean you're incidentally exposing the body to some of the fragments of dystrophin. And for some people, it tends to be a protective effect. It will allow your body to recognize those areas of dystrophin as self and not generate autoantibodies against them. But for some people, there's a paradoxical effect of generating a population of innate T cell immunity towards these fragments of dystrophin in the revertant fibers. So take, for example, oops, sorry. So take, for example, this particular mutation where you have a deletion in exon 45, and then we try to look at this patient with this deletion and to see along which portions of the dystrophin did we generate a autoimmunity to. And so you see the area of deletion generating the autoimmunity because it never saw it before, right? But then we also see autoimmunity against areas where typically we do see the dystrophin being made. And so when we go back to look at the constructs, there is one particular area that we realize is less familiar to Duchenne patients in general. So with SMN1 and 2, we were able to get used to seeing SMN2. With Duchenne and dystrophin, there is a homologous protein called utrophin that exists in immature muscle cells and muscle stem cells and then gets converted to dystrophin. However, this utrophin does not contain this area, making this region highly, highly immunogenic. And so a lot of the constructs nowadays, when we are trying to treat patients, we screen for people who have deletions within this area because it makes them highly susceptible to myocarditis, etc. And so as a result, unfortunately, the current constructs are no longer one size fits all. There are certain patients who are definitely not suitable for this. So this is the last bit of the topic, I promise. So it's looking at the next generation AAV where we modify it to be more myotrophic, so therefore reduce the viral load, and also along with that, reducing the burden on the liver, reducing the immunogenicity. And this is something that is, much more recent, but it was, and there's a lot of different constructs tried, but it did show some promise in the solid bioscience construct that is still undergoing clinical trials, where this year in the Muscular Dystrophy Association meeting in March, they were able to show that a much higher delivery efficacy, and that definitely, as much as they know right now, dosing only 3 patients, that it appears to be as safe as a Sarepta construct in comparison. So the dream of delivering the whole sequence of dystrophin still lives on. There's a lot of fancy genetic engineering at play where we try to deliver the parts of dystrophin via AAV or something similar in pieces, have it recombinate in our body to generate the whole protein. So there's still a lot of ongoing work in this area as well. But regardless, the current disease-modifying treatments have definitely changed the landscape, and the outlook for these children. And as a result, I do suspect that these kids will gradually age and come to your adult clinics, and you might start seeing more of the SMA type 1 babies, the more classic Duchenne patients aging into the adult field. And unfortunately, it does potentially mean that they might have different healthcare needs at the time. We'll continue to monitor this landscape. Now, it also speaks to my personal belief that being a neuromuscular provider means that there shouldn't be an age cutoff, that the disease is the disease, and that we should be try to be comfortable as we can at looking at all ages across that spectrum. So that concludes my talk for today. I really appreciate your attention, and I'm open to any questions.
Thank you, Ava, for that talk. I know some people have to get to clinic, and I'm just monitoring the chat for questions. Question from Dr. Doherty. He says, great talk, Dr. Lin. Thank you for your team and your work. What is the speculation in Duchenne's children as to why a motor gene might be associated with autism or epilepsy?
Yes, that is a very good point. So the dystrophin has a lot of internal open reading frames and is expressed in several different organ systems as well. So it is present in the brain, in the eye, to say the least, in the retina, to say the least. And so if you have, and for the isotypes of the dystrophin in the brain, right, it really relies on a healthy N-terminal part of that gene in order to fully support the structure and function and development of the brain tissues. The intricacies of it, I don't know that we have had a chance to study it as well, but it is definitely something that has come to the forefront, particularly over the past decade.
I'm not seeing any other questions in the chat. People feel free to just speak up or raise your hand. I have a question, not to put you on the spot, Dr. Lin. Your talk focused on SMA and Duchenne, but I was wondering, in the landscape of all the neuromuscular diseases, do you think there are any other viable targets?
No, absolutely. So, and each disease is unique in its own right, because it really depends on the baseline pathophysiology. But we definitely have similar amounts, advancements seen in, say, myotonic dystrophies, the facioscapulohumeral dystrophy, FSHD, ALS, although that is it's a very heterogeneous group by far, and so that's been challenging, and Charcot-Marie Tooth as well. In fact, there might be clinical trials available for patients to participate for CMT type 1 that's hopefully coming up in the next 6 months or so. So this is kind of globally expanding across different disease conditions for neuromuscular conditions. And it is a little bit of a challenge to keep up to date with everything that is going on in order to provide the best information for the patients. But I do feel that that's kind of where the neuromuscular field can provide the best service at this time. I see that Dr. Bolden asked why the bulbar musculature is particularly resistant or affected despite treatment. I don't know that we know the reasoning behind that. We know that the SMN protein is important for motor neuron survival, but also for a lot of different functions as well, including mitochondrial function. And so it's really more of a systemic disease than just simply motor neuron. So there's something about our bulbar system that makes it less or I should say more reliant on having really robust amounts of SMN. I don't know that we know the exact details from the pathophysiology perspective, why that area is much more susceptible. It is an ongoing research. And one of the ways that we were hoping to approach that is with the advent of risdiplam, so the oral exon skipping, comparing the oral exon skipping, which is more systemically available, to that of the intrathecal injection of the nusinersen, right? But there's a couple challenges with that. I mean, in an ideal world, we would be able to do a direct comparison. However, you're essentially asking these companies permission to compare one against the other, which is always a little bit politically challenging. And then the other aspect is the fact that risdiplam has not been approved for very long. And so we definitely need a lot more years of open label data in order to even attempt to do an analysis like that. Otherwise, I really appreciate you allowing me to speak on this platform. Seattle is definitely a near and dear place in my heart, and so really always happy to interact with people in the area. If there's anything else that I may answer for you, please feel free to reach out. I suspect Dr. Ko would have my contact information. And thank you so much for your attention.
Thank you so much.
Thank you. Have a good day, guys.